is a 40-year-old gentleman who is a software professional and an extremely apprehensive individual. Has a low-velocity bike accident and presented to us with a supple compartment. There were no blisters or swelling at the time of presentation, and these were his X-rays on presentation.
So, panel, with these X-rays, any first thoughts on what do we have and what's your plan?
So there is, of course, CT would be done, but on X-ray also we have so many findings to see. So there is a gross depression of a lateral plateau fracture, which has gone way down. And when the fragment goes so down, I would always suspect a lateral meniscus to be trapped. That would be my first thought process. Posterior column is gone. So there is a fracture, there is gross displacement, and I would be suspecting a meniscal injury.
Right. So Rajiv, starting with you, thoughts on how do you want to tackle it?
There are 2D images as well.
This is a very large posterolateral fragment.
So Rajiv,
Yeah.
so this is 3D to see. You will like to see
I
any
said
other?
before 3D, I would like a axial cut.
Axial
I don't like a 3D. I like to, yeah. Yes. There's apex, yeah. Depressed posterolateral. So this thing is gone.
So the dilemma would be the approach here.
Approach here. Do you have an axial cut?
Let me see.
Okay, from top. Oops, yeah. So basically, he's got a anterolateral and this is a posterolateral fragment going down. This is the metaphyseal fragment is posterolateral, isn't it? Can't make out in this. Front, back. There's a back, isn't it?
So one approach, two
This is
approach,
back.
Rajiv.
This is back. The first one is posterior. The first one is posterior.
Sandeep?
So basically,
Yeah. Go ahead, Rajiv.
You want to complete?
so basically, if you want to analyze this patient has got a lateral side alone fracture. It has got an anterolateral compression with the whole articular surface being driven down. That's mainly anteriorly, but the metaphyseal beak is going down posteriorly also.
Approach. How many approaches?
Two separate approaches. Posterior approach to fix posteriorly by a buttress plate, then by anterolateral approach elevate the depressed part, central part of the lateral condyle, which has gone down right there, and fix it separately with the anterolateral plate.
But what
Would
will be the
require-
sequence by which you will go?
Would posterior first,
Well, once you have done posterior fixation,
only distal screws, not the superior screws.
okay.
But in that posterior, you will not be able to put in a T because of the vascular limitations. So beyond 5 centimeters, as such, you can't go. You can't go the standard way as you go the middle way there.
Sangeet. So what sir means to say is that the beak is so inferiorly. Would you go with the posterolateral approach because you need to go beyond the beak to buttress it?
Swapnil? Basically, as sir has said, the beak is far inferiorly than 5 centimeter on the lateral side.
Yeah.
So there is no point in going from posterolateral side. It is a little bit difficult. So it's better, like Jignesh showed, it's a posterior medial incision. From here you can reduce and put a plate from lateral to medial. It is an oblique plate which need to be placed. First thing. Second thing, why in this case the sagittal scan is also important, because this posterior wall is not having any comminution. So you can just buttress it with the plate. Even if you don't put the proximal screw, it's okay. Then make the patient in supine position, just open book the lateral wall, the fractured lateral wall, elevate the 1 inch down your articular bone. The subchondral level with the submeniscal approach. I fix it with temporary 2 millimeter K-wires, 2 or 3 K-wires exactly in the subchondral bone, and then reduce the lateral wall, and I pass this K-wire again from medial to lateral side, holding that lateral wall, and then I fix with a raft plate.
Will it require a graft?
Okay, so my threshold will be if the intraarticular piece which has gone down, if it is having a good subchondral bone, then I will not put a graft. But if there is only a cartilage or little bit of bone, then I am sure I have to put a graft here. Otherwise it will sink.
But with a void that's so big and it's gone so down, I mean, you need to support it.
Swapnil, will you take help of your scope while putting the piece in the proper position?
Sir, with submuscular approach I think we can do. If it is little bit difficult, then we can put a lateral fixator and distract it.
Front, and then you go in, look straight down, and when you bring it up,
Dr.
I mean, that's usually you
Yes.
see it in front of your eyes.
Yes.
So you have to put that block of cartilage with bone. It's quite a big. It's about 2 centimeters. Once it comes back into its place, the job is done. And here that meniscus will definitely be trapped. The meniscus will definitely be trapped inside the joint. This is one of those classical cases where you find the meniscus inside.
Dr. Ajit.
Because we are expecting meniscus to be trapped, that is why I asked Swapnil whether he will like to take help of a scope.
Sir, with the
To have a
submuscular
look
approach, I
inside.
mean, with the when you are opening the lateral fragment, you can directly see the meniscus. So it's almost like a submission. Here you can take few stitches to the
So Dr. Ajit and then one at the back. Yeah, wait.
I think here the history is very low velocity we thought. But in a young man with such a severe injury, you need to suspect medial ligamentous injuries here, medial collateral or something that going that far down. So an MRI will rule out that or help us in that as well as for the meniscal trapping. The second is the position, whether you're going to do a floppy lateral position, prone, like you said, that would be a best approach to fix this, and then turn him over to save time, and then the question of bone graft. These are the things that we need to plan before we go in.
Okay, question
I think
from
that's where the floppy
yes.
lateral-
Question to Sangeet sir. He said posterior first, but if you see the CT image now, if we push the posterior, the block which is there of the articular surface, it will prevent the buttress. And plus, once we push it, it will be difficult to get the block up. So is it better to first elevate the block and then do the buttress?
For elevation, it requires a base, a foundation against which you are going to elevate. If it doesn't, if the posterior fragment is not buttressed, that elevation will go haywire and that posterior fragment will get displaced. So it has to be fixed first, elevate it on the basis of that, and then reconstruct it.
Because it is depressed so much, will it not get locked if you buttress it? If you see this image right now, the CT image,
you fix the posterior wall first. On the lateral side, okay, because of the depression, there is a gross combination, even in the metaphyseal area. So it will not prevent the reduction of posterior wall first. Second thing, reduction of posterior wall will not impinge that fragment. You still can lift up with the artery force because there is a combination. And in the metaphyseal area, it is little bit easy to remove that fragment up.
Or other option is just lift the apex and push that fragment up.
Okay, so in the interest of time, Ashish, go ahead, then we can do one or two more cases.
So I agree with Dr. Ajit's suggestion that MRI could have been done for the MCL, but for the lateral meniscus we were going to do an arthrotomy anyways. So the issues that we had highlighted, so we had the option of going anterolateral and posterolateral or an extended anterolateral approach or a dual approach as everyone mentioned. So what we did was basically we explored through the posterior medial and the anterolateral approach, and as was suggested by what Dr. Swapnil mentioned, and someone asked in the audience, can you use it to fix the posterolateral fragment? So we used the oblique plate to sort of create a buttress against which we could elevate the fragments and against which we could sort of bone graft it, elevate the fragments and repair on the anterolateral aspect. So we did in the floppy lateral position, which was described by Leo. It is like a hyper floppy lateral, so it's almost like a prone. So you can access the posterior middle fragment from the opposite side. The surgeon changes sides, and then you flip the patient again on the lateral aspect to the anterolateral aspect.
Are you happy with the slope, the posterior slope there? And why such a long plate?
Yeah. So
There appears to be some step here or either a change in the posterior slope.
yeah, so
Is it a view?
No, I think you are
Or
quite
if you
okay
have
with-
subsequent view, probably things will be clear.
Let me check. So this is a view at the follow-up. So why such a long plate is basically we decided to go long for a bigger, longer span. But yes, we could have used a 2-hole shorter plate. I mean, the only point, the slope also we were happy. The only thing which was not very convenient, it was like trying to close a door from the first floor. Yeah, it was like, trying to get the posterolateral fragment reduced from the posteromedial approach is trying to close the door from the first floor, So we couldn't pass a screw in the posterolateral fragment on the proximal fragment, on the proximal side like we were mentioning. So we just had to use it as a buttress and raise the sort of depression from the anterolateral approach.
Rough screws may have avoided that. You may have got the reduction on table.
Yeah.
Maybe rough screws there would have, this may have been a little later collapse.
Okay.